Anybody who's got an infection, you're outnumbered by 1 billion to 1 trillion to 1, okay? And every one of those little buggers has the ability to reproduce every 20 to 30 minutes. And every time they reproduce, they can make a gene switch and develop resistance, just like that. So it is war, we're outnumbered, and we need weapons. And one of the weapons that we've always had for the last 100 years is antibiotics, except we now have a very, very aging arsenal that is not being replenished.
And just to put it in perspective, when we say expensive agents, these are not your $300,000 a year drugs. Your average branded agent of antibiotic runs about $300 to $500 a day. And so if the average course of treatment is about, say, 10 days, you're talking about $3,000. Well, the average cost for a resistant infection to the hospital system is about $30,000. So you're talking about less than, about 1/10 of the total cost of a resistant infection is due to drug costs, right? So these are not hugely expensive drugs. So, when we say expensive agents, that's relative to pennies a day generics, which are generating the problem that we're all facing.
And I think that's an important point in terms of what really is the cost of the decisions that are made. So the pharmacy piece of that overall cost picture is a very tiny part of it. So if a patient requires readmissions or their underlying condition continues to deteriorate because their infection is getting in the way of treatment, then not only is there a very large societal cost to loss of life and loss of productivity, but there's a loss of healthcare investment costs. So the treatments for the patient who has an underlying comorbidity that made them susceptible to this infection, readmission rates, extra days in hospital, extra days in the ICU. I mean, these are all factors that need to be considered in terms of how we structure this infrastructure. Antimicrobial development is a public health issue, and it's a public health issue that is not as attractive for investment because of how the products are treated post-approval. So what we are working towards is to develop solutions where you uncouple or you de-link the usage with the financial incentives.
That principle of delinkage is behind a lot of this legislation, which is to separate the ties that actually drive bad prescribing behavior and disincentivize companies from actually being in this area. This is an infrastructure need. This is like roads and bridges. I think the military procurement analogy, again, you buy a bunch of F-35s, you're not using them every day, right? And Lockheed Martin is not making money based on the usage, but they're still needed. And they're also very expensive, but you want to have them, and you want to have them available in case they're necessary.
Some of the EWG's current activities are focused on the elements of what's called the Disarm Act, which provides a new technology add-on payment for drugs that can treat these pathogens. It doesn't make economic sense in the current paradigm in a hospital to administer a branded antibiotic. What the Disarm Act would do, should it pass, would provide what is called an NTAP payment. So it just really reduces that impediment for the hospital pharmacy director to not reach for the correct drug. Another piece of legislation we're working on is called the READY Act, which provides a 50% R&D tax credit to innovators who bring a new drug to market. What that means is that if you spent, let's say, $100 million in development from phase 2 to phase 3 and get that drug approved, $50 million of that, 50% of that, could be translate into an R&D tax credit. And that tax credit could be transferable. So that could make it attractive for a larger pharmaceutical company, which isn't investing in discovery, but maybe they want to partner or acquire your company because they can get the benefit of that tax credit. So these are the types of things we're currently focused on. And certainly what we have our eye on are these market entry rewards.
Imagine trying to hit a buzzer beater from mid-court. Imagine that backboard is actually now moving in time, which gets to the point that Eugene made. They're developing drugs right now, but that backboard is evolving, right? And these pathogens are smart, right? They've been with us since recorded human history, right? I mean, you can pick up the Old Testament and you can see descriptions of bacterial infections. So the touchstones here with infection, since it can touch anyone, it's almost as if it's a problem of the commons. No one owns it. And that's exactly where we are, which is why I think the organization in this room are important, because you advocate from a different perspective. You represent policymakers, you represent patients, you represent charities with resources, and all of those voices need to be heard, because in the absence of those perspectives and those stakeholders, because I think stakeholder is the right word, without those voices at the table, then we get drowned out. And I think that's important.